In contemporary skull-base surgery, there are three approaches that we use to surgically remove acoustic neuromas. The choice of the approach is very important. It should be tailored to the individual patient, his or her symptoms, the size of the tumor, etc. The patients have to understand the nuances of these three approaches in order to make more of an informed decision when they talk to their surgeons about what is best for them. The approaches we'll be talking about are the translabyrinthine approach, the retrosigmoid approach, and the middle fossa approach. I'm going to use this skull model to demonstrate these approaches. This blue dot represents the acoustic neuroma, so this is a right-sided tumor that's going to get removed. The translabyrinthine approach is an approach from the side of the head. All this bone is going to be removed to clear the way to the tumor. The advantage is that with so much bone removed, the cerebellum doesn't need to be pushed away or retracted to perform the surgery on this tumor. This approach is only used when hearing is non-serviceable or completely absent, but it can be used for tumors of any size, including very big ones. The facial nerve is seen very early during the operation inside the canal, and perhaps because of this, for tumors of equal size, this approach is the least likely to hurt the facial nerve compared to the other approaches. The retrosigmoid approach is an approach from the back of the head. A window of bone is removed right here to get into the skull. The cerebellum is then gently pushed to the side to gain access to the tumor from the back. This approach can be used for tumors of any size, and the likelihood of preserving hearing is dependent on the preoperative hearing status and the size of the tumor. Because the operation takes place under the cerebellum, there is a slight chance of cerebellar injury. The facial nerve is seen late in the operation, so compared to the translabyrinthine approach, for tumors of equal size, the risk to the facial nerve may be just a tad higher with this approach. The middle fossa approach is an approach from the top of the tumor. A window of bone is removed right here to gain access into the skull. The temporal lobe is then gently pushed up to gain access to this area called the floor of the middle fossa. The bone on top of the internal acoustic canal is then drilled away to gain access to the tumor inside the canal from the top. This approach is probably the best one in terms of hearing preservation, but it can only be used on small tumors contained within the internal acoustic canal. And because all the work is done under the temporal lobe, there is a slight chance of temporal lobe injury from the retraction, and this could lead to seizures. So as you can see, there are a lot of nuances when it comes to picking the right approach for acoustic neuroma surgery. Which approach is the most appropriate depends on the tumor size, location, and whether the patient prioritizes hearing preservation or minimizing other risks.